You hear me? Junaid, you hear me? Doctor Junaid, तो फिर बहुत फायदा नहीं होगा ना कोई। जुनायद फोन करो, फोन करो ये नंबर फोन मिला था 0342।
सर लेक्चर एंड हो गया सर?
नहीं नहीं नेट नहीं, लाइट भाग रही है ना इसमें। अच्छा देखो, मैंने एक और लैपटॉप से डॉक्टर वसीम जमालवी के नाम से किया है,
जी
उसको
सर।
उसको जरा को होस्ट करो।
ठीक है सर, मैं उसको कर लेता हूँ।
उसको को होस्ट करो तो फिर मैं वहां से स्लाइड शेयर करता हूँ।
ठीक है सर।
तो वहां किया है, मैं यहाँ स्लाइड बंद कर रहा हूँ।
हेलो सर, को होस्ट बना दिया है सर।
स्लाइड कर दिया आपने, होस्ट कर दिया?
बना दिया सर, को होस्ट बना दिया।
हाँ होस्ट कर दिया ना। ठीक है, दैट्स गुड। चलो हम तेज चलते हैं थोड़ा सा। वी ऑलरेडी लॉस्ट आवर टाइम एंड सॉरी फॉर इनकन्वीनियंस ऑफ, देयर इज डेफिनेटली सम प्रॉब्लम इन my personal laptop. This is my son laptop. Fine, let's start again. There is certain changes we have done in my laptop, so okay, fine. Now let's go. We have finished the introduction. So there is basically a certain difference in the airway, especially the upper way of children and adult, and that is the one most important thing, is the large tongue. The large tongue is happening is what they can be obstruct easily of the airway by launching the tongue posteriorly, and there is the decreased respiratory effort by the pediatric age group. And the second important thing in the children is what, that is the narrowest part of the respiratory tract, that is the required ring, and that area there is something which is, if it is foreign body, they can be obstruct over that area. Thank you very much. Thank you. So this is the picture of different airway, and if you look at the airway over here, this is the area, the tongue. If it is in the pediatric age group, that tongue is when fallen posteriorly, as the mouth cavity is not larger as larger as the older tongue. So there is the chances of the obstruction of airway. So what are the sign and the symptom of that when there is the upper airway problem by infective cause, and there is this viral infective, bacterial infective, or whatever it is? There is the three main issues, and that three main issues is like what? The stridor, the respiratory distress, especially the supraesternal retraction, and third one is the hoarseness of voice. These are basically, with the hoarseness of voice means there is the harsh and vibratory sound with the variable pitch, and that is the resulting of the airway obstruction. So if a healthy child who is having this disease of upper airway obstruction by any cause, they can be tolerated for a couple of minutes, but when the point of exhaust, the child exhausts, when the tidal volume is decreased, not enough to maintain the hypoxia oxygen level, then there is the three main thing, and that is the hypoxia, that is decreased oxygen, hyperthermia, that means there is the increased carbon dioxide, and the acidosis. And the acidosis, they can be rapidly leading to the cardiac arrest, that is called is the cardiorespiratory arrest. So if the healthy child who is previously healthy and there is an obstruction and there is a decreased respiratory effort, so there is three things they can be lead to the cardiac arrest and increased chances of mortality. Then how you check, how you know if where is the problem? Basically, there is three areas: the supraglottic area, glottic lesion, or the subglottic area. In a supraglottic lesion, if there is inflammation or the infection or the obstruction, whatever it is, that is in the supraglottic lesion, then this is called the epiglottitis. And in epiglottitis, the child can be presented with the inspiratory stridor and prolonged inspiratory phase. The inspiratory phase is prolonged with the muffled cry or voice. But if there is the glottic lesion, the main in the glottic area, the lesion, then there is a lead to high pitch inspiratory stridor and weak or hoarseness of voice. But if it is below the glottic area, that is called the subglottic lesion. In case of subglottic lesion, there is the one most important change is the expiratory stridor. In previous to supraglottic and glottic area, there is the inspiratory stridor, but here is the expiratory stridor with voice is normal, but there is a brassy and a barking cough. This is the typical presentation of all three areas when there is the inflammation by infective cause or obstruction, whatever, then they can be presented with these type of presentations. If we failure to manage this airway obstruction, then this is the leading cause of preventable death in the children. What does it mean? That means if we can save this child if we properly manage and appropriately manage with time, then we can save these children properly save their life. So there is basically two main diseases of this upper airway obstruction or upper airway inflammation. One is the viral cause, and the second one is the bacterial cause. The viral cause is with the name of croup. This is also called is the laryngotracheal bronchitis, and this is the most common cause of upper airway obstruction. And approximately the 10% of the children who presented into the ER with the diagnosis of croup, out of that 10% may require admission, and about 1 to 5% of children with the diagnosis of croup may require intubation or ventilatory support. What is the pathophysiology of this disease? Basically, it's a viral disease. As I previously told you, it's a viral disease, and this viral disease is basically transmitted to the child from another child or whatever the person. There is the airborne disease, and the initially part of entry of this infection is the nose and the nasopharynx. There is the prodromal sign that initially are you aware of that there is the incubation period, the virus is in growth in that specific area, then there is the prodromal sign, and there is 3 prodromal sign in this disease of the croup. To start with the mild nasal congestion, sore throat, and then the cough. So then this infection is spread distally to involve the tongue, because initially it is involved the nose and nasopharynx, but when there is the edema of the epiglottic area, then there is the typical presentation of the child with the hoarseness of voice, with the brassy and barking like cough, and As I previously told you, the typical presentation of upper airway obstruction is the stridor. So as I previously told you, this is the viral disease. The croup is viral disease, and the multiple viruses can cause this, like influenza type 1, parainfluenza type 1, influenza, respiratory syncytial virus, rhinovirus, or can be caused by the measles. But the most common virus they can cause the respiratory syncytial virus that can cause of croup. Usually it occurs at around the 1.5 years of age, but the age ranges from 3 months to 3 years, and slightly male predominance of this disease, slightly, but don't know why this is the male predominance, but it is slightly, the study says, male is slightly predominantly having this disease. There's a certain seasonal increase of this disease as it is autumn or in the early winter. So, what is the presentation? And these are the typical presentation of croup. Apart from that, the prodromal sign with the cold type of picture, mild fever, running nose, rhinorrhea, and then there is the barking cough, but there is the certain elevated temperature, as this is the viral infection. There is drooling. The salivation is not a very commonly presented. May have the mild expiratory wheeze and the expiratory stridor at rest with the nasal furrowing, because there is the supraesternal or intercostal retraction, and there is a poor entry, and because of the hypoxia, decreased oxygenation in the child, they can be presented with the initially there is the agitation, but later on they can be presented with if there is a severe hypoxia and decreased oxygen, they can be presented with lethargy. As the child is not taking properly and an increased respiratory rate, so there is the chances of the water loss, and they can be sometimes presented with dehydration as well. So how can we diagnose croup? In the diagnosis of croup, there is the Wesley scoring system. It is initially clinical, and a child who presented of the age between 3 months to 3 years. With the initially, there is the prodromal sign of the upper respiratory tract, like flu and coryza and all these things, and then he can be developed with the barking cough. So, and it is suspected case of the croup on the basis of barking cough and a stridor, but the diagnosis based on two things. Number one is the Wesley scoring, and this Wesley scoring is based on the 5 things: the retraction, the suppressor retraction, the air entry, presence of the stridor, presence of the cyanosis, and the level of consciousness. And the score ranges from 0 to 17. The maximum the scoring means there is the maximum of the severity that indicate the severity of the disease. And 85% of the children who presented into the emergency department usually have the mild disease, and a severe disease of the croup is very rare. As I previously told you, only 10% of children require admission, and out of that 10%, usually 1 to 5% of the children, very minimal amount, may go to having the respiratory support. So the severe disease is rare, but usually they can be presented with a mild to moderate type of variety. This is the scoring system for the prognosis of the child. We can day-to-day these 5 factors, can assess these 5 factors and check what is the situation of the child. But the diagnosis is basically, this is the rating of the different things, like in stridor 0, 1, 2, retraction 0, 1, 2, and 3, but cyanosis 0, 4, 5. And the level of consciousness, there is 2 things, 0 or 5, and air entry 0, 1, 2. That is, if we count it, that is maximum is 7. And as you all know, if we start with the 0, so the 0 to 17. But the diagnosis is basically based, and a confirmed diagnosis, on the X-ray. In the X-ray, there is the AP X-ray, and in that X-ray, there is the stable sign. That is the typical, or the second name is the pencil sign. You look at the X-ray just here, there is look at are like a pencil type of presentation. This is the AP X-ray of the neck, and there is this is the a nib of the nipple, nib of the pencil. And you look at this. This is the typical X-ray of a group, and there is because of the inflammation of the supraglottic area, and there is the compression of the airway, and this is the trachea, and this is typical the presentation of the other you called it the pencil sign or the staple sign. So how will we manage? And the management, it's a viral disease, so there is no need of no need of giving the antibiotics. But there, if there is a you suspect there is the secondary bacterial infection, then you can go for the antibiotic. Otherwise, there is no role. Just to humidify oxygen and the racemic epinephrine. But there is steroid are still controversial. The different school of thought. The one study said there is slightly improvement by giving the steroid, but mostly the study said the steroid is not very much helpful for the management of this disease. Albuterol is basically bronchodilator, and albuterol treatment we can give it the albuterol with the help of the nebulizer. And the nebulizer they can be the bronchodilation, and there is the increased airway. And the racemic epinephrine is not very commonly available in our setup in Pakistan, but if it is available, this is the treatment of choice for giving the increase. It basically will decrease the work of load of the child and increase oxygenation. So this is the treatment of flu. The second topic is epiglottitis, and the second topic is epiglottitis, and it's with the name. This is the area. Then there is the above the glottic area, and this is also called the supraglottitis. And again, the 60% of male dominance of this disease. And a group is also there is no the number is there, but that is again group is also the male dominance. But that why don't know why, but the epiglottitis is the bacterial infection, and it's usually occur in elder children as compared to the group, and it is usually occurring in 3 to 7 years of age, but only 4% of the children who presented with the diagnosis of epiglottitis of less than 1 year. And the most common organism they can be caused the bacterial infection of epiglottitis, that is Haemophilus influenza, the most common etiology. But the other viruses or the sometimes there is some allergic reaction or physical or thermal injury can play a part of that disease, and sometimes there is the inflammation because of this different thermal injury or physical injury or allergic reaction, and very rarely there is a viruses can cause, but the most common cause of this disease is secondary to the bacterial infection, and that bacterial infection is H. influenza. Okay. If we follow what happening in pathophysiology, basically there is the local invasion of the epiglottic area, and that organism is again this is the airborne disease. This organism is go into the epiglottic area, and this organism is go into the blood, and they can cause the bacteremia, and then is a false vocal cord or supraglottic stricture become inflamed, edematous, and leading to the narrowing of the respiratory tract, and ultimately the respiratory compromise. So if there is the inflammation of the supraglottic area, so there is the inspiratory airway occlusion. Basically there is two phases, the inspiratory phase and expiratory phase. If there is edema, then it is difficult to take a child the respiration in, and this is the typical presentation of epiglottitis. In case of epiglottitis, this inspiratory part of the respiration is very difficult. Okay, the swollen epiglottic area is, if we look at in the X-ray, that is called is the thumb sign, and again the different thing like the thickened epiglottic folds, and obliteration of medulla. These are the three different things. And if we look at the lateral X-ray, look at here, this is like a thumb, and this is the inflammation of the supraglottic area, and they can press the trachea below above the epiglottis, and this press can cause the decrease of the air entry, and this is the typical presentation. Look at here, this is a very good picture and an ideal picture, bookish picture of that X-ray, and this is the thumb impression of this epiglottic area, and this thumb impression means there is the compression of the respiratory tract, and this respiratory phase is very difficult in the child. So what is the sign and symptom of this disease? So it is, as you know, a very rapidly progressive disease. So it is suddenly started and very progressively and very rapidly involve the epiglottis, and the child can be presented with the muffled, very minimal cough, but the muffled voice and a muffled cry, very low pitch of the cry. Sore throat, fever, and a hoarseness of voice. But the one and most important thing they can be checked, that is the drooling. That is the difficulty to swallow the saliva. So there is the drooling of the saliva of the child, and this is the typical presentation of the epiglottitis. And the other thing is the intercostal muscle retraction, as this is the airway obstruction. So the other muscles, apart from the diaphragm, the other muscles of the respiratory system, they can be involved. And in case of that involvement of that respiratory tract, so there is the chances of the use of accessory muscles. And the other thing, apart from that, there is the noisy and high pitch inhalation with the purple skin and nails because of hypoxemia. If there is the oxygen level is decreased, so the oxygen level is decreased, so there is the hypoxemia. In case of that hypoxemia, there is the skin is in a purple color, or the nail in a purple color. Purple color means there is the cyanosis. This is basically not the central cyanosis. Usually they have the peripheral cyanosis, but sometimes they can be presented with the central cyanosis. What is the difference of these two cyanosis? In a peripheral cyanosis, there is the cyanosis usually in the fingernails and the skin that can be color of the change, and that is from the pinkish or whitish to the purplish in color. But in case of the central cyanosis, the cyanosis is usually appear on the nose, tongue or air lobules. These are the difference between the central cyanosis and the peripheral cyanosis. And sometimes they can be presented with the head posture that is called the sniffing position. And why the child can be presented with the sniffing position? Because they want to take air in an inspiratory phase. Inspiratory phase, they can be take the respiration in a different position, and usually in the odd head posture there is the slightly airway increase. And the other thing is the tripod position. And in a case of tripod position, again, that is the same thing. In that position, there is slightly relief of that obstruction, and the child can take respiration in. This is the two typical presentation of the child who are basically having this disease of epiglottitis. This is a very important thing for the epiglottitis. The name is 4Ds. This is for the diagnosis of 4Ds, and if these 4Ds is labeled as the drooling. Drooling means the salivation, because they are not taking the saliva in. So there is the salivation. This is called drooling. Number 2 is dysphagia, because as there is not the saliva in, they are totally not eating anything, or even they not take the water. So this is called dysphagia. And number 3 is the dysphonia. Dysphonia means that there is the respiratory sound is very little or very low. This is called dysphonia, and the dyspnea, the increased respiratory rate. So this is the 4Ds: drooling, dyspnea, dysphonia, and dysphagia. And this is the typical presentation of the disease with the respiratory tract, upper respiratory tract infection, mostly secondary to the influenza, monoplus influenza, and with the name of epiglottitis. So, in a child who is a children with the epiglottitis, if there is the airway obstruction, basically why the airway obstruction and what is the typical presentation step by step. We start from the down. If we look at not from the up, basically there is the pooling of secretion. The secretion is there is the inflammation of epiglottic area. They compress the respiratory tract and a trachea, and simultaneously there is the pooling of the secretions, and they can be increase effort of the child, and there is the decreased inspiratory phase and inspiration of the air. So this is the first step. Secondly, there is the progressively swelling of the supraglottic structure, and increasingly with the minutes and with a couple of minutes. Not it is very rapidly disease, and there is the third thing is the laryngeal spasm, and ultimately there is the total spasm of the larynx, and there is the total closure of the respiration inspirative phase. Ultimately, the child is fatigued. So again, we can go for the previous slide that there is the three things: hypoxia, hypercarbia, and there is the acidosis that ultimately turn out to be cardiac arrest. There is severe hypoxia and hypercarbia. They can be cardiac presented with the cardiac arrest. So this is the disease of very rapidly progressive disease. And if we pick this disease early and start treatment, we save life. And so in one slide, in an initial introduction, we told you that this is the preventable disease. And if we pick early and start treatment early, so we can prevent the mortality because of this disease. If we compare these two diseases like croup and epiglottitis, if we look at this, the one by one we can check. In a croup, the voice is hoarseness of voice, very, 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 very dangerous, horse-like voice, type of the presentation. And in case of epiglottitis, this voice is muffled. Sound is totally very low and low-pitched sound, and the sound is not produced properly because of the severe inflammation. If we look at, there is basically almost 7 or 8 points we can check in these two diseases, and we can differentiate. In croup, the cough is barking type of cough, type of the cough, but in case of the epiglottitis, usually they cannot present with the cough. Usually the cough is not present. But if the fever, as you know, both are the infection, the croup is usually the viral infection, but very rarely they can be present with the bacterial infection, and the epiglottitis is the viral bacterial infection, but very rarely they can present with the viral infection. So the fever is common in both diseases, but the fever is very high in epiglottitis as compared to the croup. Sorry. Okay, fine. Then we look at the saliva. In a croup, saliva can be ingested, but in case of the epiglottitis, the saliva is drooling, and they can be a typical presentation of epiglottitis. And then we check the neck swelling. In a croup, that there is no neck swelling or very little neck swelling, negligible type of neck swelling. But in case of epiglottitis, there is a very severe and huge swelling of the neck externally, and they can depress the respiratory tract, and that's why there is the presented with the thumb sign. Uh, it is croup is begins slowly and with the prodromal phase, that is with the slightly running nose, cough, coryza type presentation, and then they can be presented with the barking cough and hoarseness of voice. But in case of epiglottitis, this very rapidly progressive disease. Maybe the child in the when he slept, he was normal, but in the middle of the night, he can develop the muffled sound and a cough and a fever, and there is the drooling of saliva. So it's a very rapidly progressive disease, and croup is usually in the autumn, but epiglottitis is the disease who can be have in all year in any season, because there is the bacterial infection. Usually the croup is presented after the evening or in the nighttime. In the nighttime, when in autumn there is the temperature is down, and then they can be presented with the croup. But the epiglottitis can be presented at any time of the whole day. So these are the different points of differentiating the croup and the epiglottitis, and you very safely differentiate the something like the one thing is important, the barking cough. Sorry, stridor. Stridor is common in both disease. Stridor means that there is the upper respiratory tract infection. Then you can differentiate in two, three things. If there is a hoarseness of voice, barking cough, and there is no drooling, that means that this is croup. But if it is the voice is muffled, cough is low, but there is the drooling and the neck swelling, that is in favor of epiglottitis. These are the two typical presentation of this disease. So look at this is the very important comparison of these two diseases who can be presented with the upper airway type of the presentation. So how can we treat the epiglottitis? If you, as you know, in case of epiglottitis, the everything like that, whatever. But the specific therapy is the use of antibiotic who cover the Haemophilus influenza. That is the typical presentation. Sorry, just 1 minute. Oh, okay. Oh. Okay. The important thing is to maintain the airway and do not agitate the child. The most important thing is what you know. In case of epiglottitis, if you send the child to the X-ray department for X-ray, and a child is during the transportation, if they are in an agitating state, they can be very rapidly increase of the swelling and suddenly collapse. At this situation, you have a very expertise and an expert person who pass the endotracheal tube and maintain the airway. The most important thing in this disease is to maintain the airway, and then the oxygenation. They start oxygenation, and as I previously told you, start the antibiotics. If we look at the prognosis in a viral croup, as you know, it's a viral disease, so it's a self-limited disease. And if you can maintain the oxygenation properly, so there is a very rare chance of mortality. But if there is the severe respiratory failure like hypoxia, hypercarbia, then can be go for the cardiac arrest. Although it's a very rare for the severe disease and a severe presentation, but it is one of the complication of the croup. The other thing, in the first symptom usually improve within 2 days, but maybe sometime it can be happen till a week. But the other uncommon presentation or the complication of the viral croup is bacterial tracheitis, pneumonia, or the pulmonary edema. Bacterial tracheitis, as I previously told you, the second name of the croup is the laryngeotracheal bronchitis. That means all the larynx, trachea, and bronchioles are inflamed. So this is the laryngeotracheal bronchitis. But this is the viral. But in case of there is the chances of secondary bacterial infection of trachea, so they can be converted from viral infection to the bacterial infection, and in case of that bacterial infection, they can be presented with the high grade fever. Pneumonia means that there is the inflammation of the lower respiratory tract, of the lung, and there is the typical presentation of the lower respiratory tract infection with the secondary, usually the secondary to the bacterial infection, the pneumonia. And according to the IMNCI, the Integrated Management of the Neonatal and Childhood Illnesses, this is a program of WHO program for the diagnosis and the management of the pneumonia in children from birth to the 5 years of age. That is something else, but as there is the word pneumonia used, so I just told you that is the program of IMNCI, and sometimes they can be presented with the pulmonary edema as well. So these are the different complication of this disease, and prognosis is usually good in both the disease, the viral croup and bacterial epiglottitis. But the one thing in the epiglottitis, as I previously told you, if we pick the early and continue the oxygenation and maintain the oxygen level as a properly needed oxygen saturation more than 90%, so we have a good outcome of this disease of both like the viral croup or bacterial epiglottitis. So how can we prevent this disease, this disease of epiglottitis? Epiglottitis is, as you know, this is the secondary to the disease of the H influenza, and that H influenza is with the name of Hib H influenza type B, and this Hib vaccine is included in the ETI expanded program of immunization. This is the government funded program, and in this program there is the 11 diseases can be covered with this vaccination, and H influenza type B is one of the disease which is covered by giving the vaccination, and the name of that vaccine in which there is the H influenza with the name of Penta. Penta means 5, so there is the five diseases. 5 diseases can be covered in a single injection, and that is the diphtheria, tetanus, pertussis, hepatitis B, and Hib. Hib means H influenza type B. So these are the different diseases which is covered, and there is the certain a good number of the vaccination. So the diphtheria and the Hib is not as common as previously before this program started. This program was started around 25-30 years back in 1978, and now it is on peak level of giving the vaccination to our children. So taking the benefit of this lecture, I told you it is your duty of as a healthcare worker, you can be counsel to your nearby, whatever it is, your children, your cousins, your maid children, or whatever, they should be vaccinated properly to save at least 11 diseases, which is either very high mortality or very high morbidity. Like the polio disease, that is the very high morbidity and the lifelong deformity of that disease. So this is the prevention of that disease. For this lecture, I made this lecture from the Airway Obstruction and Infected Children, that with this